Hemostasis. Hemostasis basically is a process that initiated due to a vessel injury. Basically, there's some type of an injury to a blood vessel. In order to control this injury, a process of hemostasis is activated. So basically, in general, hemostasis means formation of a thrombus or a blood clot. Again, like I said, it forms in a case of a blood vessel injury, and it can be divided to primary hemostasis, which is a creation of a platelet plug, and secondary hemostasis, which makes the platelet plug stable. And let me do a quick explanation about this. So if we have a blood vessel, and let's say this is the endothelial cells of the blood vessel, and for some reason the endothelial cells are damaged. So this damage to these blood vessels will cause, basically the goal is to form a platelet plug. So platelets will come, they will stick to the endothelial cell, to the blood vessel wall, and I will explain it how it happens in a couple of slides. But basically the platelet will stick and platelets will aggregate. So in primary hemostasis we have a formation of aggregation of platelets, and basically formation of platelet plug. But the problem is that this platelet plug is weak. So in order to make it stronger, we have a process called secondary hemostasis. Basically, secondary hemostasis is a process that is mediated by something that is called coagulation cascade. And again, I will explain it. I will explain the coagulation cascade in a couple of slides. But this coagulation cascade basically stabilizes this platelet plug, makes it stable. This is basically secondary hemostasis. Primary hemostasis. So like I told you, primary hemostasis is a process where we have formation of a platelet plug or a blood clot, and this is basically unstable platelet plug and a blood clot formation, and I will explain to you how this process occurs. So basically, initially the first step that happens is constriction of the damaged blood vessel. This constriction of the blood vessel is basically like a response of a blood vessel to the initial response of the blood vessel to the injury. And this process of the vasoconstriction is mediated by neural stimulation due to the injury, and more importantly, release of endothelin by the endothelial cell. And this release of endothelin by the endothelial cells mediates the process of vasoconstriction. Then the second step of primary hemostasis is called platelet adhesion. Basically what it means is that due to the injury to the endothelial cells, the subendothelial collagen is exposed, and subendothelially we have special granules. Those granules are called viable Palladi bodies, and I have the spelling, the correct spelling on the slide, which I will show you in a couple of minutes, but just concentrate on my words for now. So those special granules called viable Palladi bodies, they contain two things. For our topic, the thing that is important is WVF, or in short, von Willebrand factor. Okay, so viable Palladi bodies, special granules in subendothelial, inside the endothelial cells, they release the mediators, which include von Willebrand factor due to injury. Sorry, I got it wrong. supposed to be like this. Von, the V is first, von Willebrand factor. So there is von Willebrand factor due to an injury. The second mediator that they release, and I will only mention it, but I will not elaborate because it's not related to our topic, is P-selectin. P-selectin. And I'm only mentioning this is because I want to show you the name. So the name is viable Palladi bodies. Viable starts with W, so you can remember von Willebrand factor. And the second name Palladi starts with a P, so you can remember P-selectin by this. So viable Palladi bodies, they release the mediators, and in case of one Willebrand factor, it will stick to the subendothelial collagen of the injured endothelial cell, and basically when platelets will come, they contain special receptors. Those receptors are called GP1 beta receptors, and those GP1 beta receptors will connect to the one Willebrand factor. So, like to summarize it, you can say that one Willebrand factor basically connects the subendothelial collagen to the GP1B receptors, released again from the viable Palladi bodies. And this basically causes the initial platelet aggregation to the endothelial cells. I should also mention that the primary source for one Willebrand factor is the viable Palladi bodies inside the endothelial cells, but the platelets themselves contain special granules called alpha granules, which also contain one Willebrand factors. But the main source for one Willebrand factor is the subendothelial cell. Is the endothelial cells themselves that contain viable Palladi bodies. So let's go to the slide. Again, first step in primary hemostasis is mediated by neural stimulation and endothelin released from damaged endothelial cells, which causes transient constriction of the blood vessel. And the second step is the platelet adhesion to the blood vessel surface. And the mechanism of it is one Willebrand factor that is released from viable Palladi bodies at the level of the subendothelial collagen, which binds to GP1B receptors of the platelet. So the next step in primary hemostasis is called platelet aggregation, and I will explain it to you. After the initial adhesion of the platelet through the GP1B receptor to the one Willebrand factor, basically this aggregation, this adhesion, causes the platelet to degranulate. The granules inside the platelet will degranulate. This degranulation releases two key mediators. First key mediator is thromboxane A2. Thromboxane A2 is a chemical mediator that comes from cyclooxygenase derivative. I will elaborate on cyclooxygenase on different lecture, but let's for the purpose of this lecture, let's just say it's a derivative of cyclooxygenase of platelets. So platelets will degranulate, they release thromboxane A2. Thromboxane A2 promotes platelet aggregation, and the second mediator that is released is called ADP. Now, the job of ADP basically ADP will stimulate through autocrine stimulation. Autocrine stimulation is when something releases its own molecule, which stimulates the thing that released it. So in this case, platelets release ADP, and ADP will stimulate the platelet. And the ADP will cause the platelet to express another receptor. Actually, it will express not one receptor, it will express two receptors. So let's make those receptors black to differentiate them from GP1B. Okay, so those receptors are called GP2B and GP3A. So again, this process is called platelet degranulation, and basically the connection of one Willebrand factor to GP1B receptor on the platelet will cause the platelets to degranulate, and this degranulation will release thromboxane A2, which promotes platelet aggregation, and also ADP, which auto-stimulate the platelets themselves and help them to express GP2B and GP3A receptors. And the importance of those receptors is that fibrinogen. Okay, let's put it in a different color. Fibrinogen. Again, another molecule. I like to think of fibrinogen as a linker molecule. Basically, it's used for linking. So this fibrinogen molecule will be used as a linker to another platelet. So fibrinogen will come and it will sit on GP2B or GP3A receptor, and another platelet will come and again with GP2B or GP3A receptor will connect to the fibrinogen. Okay, and this is how a platelet chain will form. This is how a platelet plug, aggregation of platelet forms. So this will connect to it. Then again, this platelet will have GP2B, GP3A receptors, and again fibrinogen will come, and again another platelet will come, and this will form a chain of platelets. So this is basically the mechanism, the idea of platelet aggregation. And again, this platelet formation is basically it forms a platelet plug that is weak, and to stabilize it, we require a secondary hemostasis. Basically, we require the coagulation cascade to work on this complex. So let's go back to the slide. So the first step is platelet degranulation, platelet adhesion that causes platelets to degranulate and release multiple mediators. The important mediators are thromboxane A2, which helps platelet to aggregate, and ADP, which expresses GP2B and GP3A receptors on the platelets themselves by autostimulation, and this is important for aggregation because and step 4, which is platelet aggregation. A fibrinogen molecule links GP2B and GP3A of platelets to another platelet, resulting in a chain of platelets, which is called platelet plug. So now let's talk about secondary hemostasis. And basically, secondary hemostasis in general means stabilization of the weak platelet plug. And this occurs by the coagulation cascade. Now, the coagulation cascade, basically, there are factors which are produced by the liver, and they are produced in an inactive state, and they are released to the blood. And in the blood they are floating until they get activated. So let me just let me elaborate on it. This coagulation cascade basically consists of factors. So we have special factors, and we have those factors. They are divided into three pathways. So I have a good method to remember it. Those factors, they are divided to intrinsic, extrinsic, extrinsic, okay, and the common pathway. So we'll start with the common pathway. The common pathway basically consists of factor 10. Okay, X is 10 in Roman numerals. Factor 5, factor 2, and factor 1, which is called basically a thrombin. And the intrinsic pathway consists of factor 12, factor 11. Now remember that factor 10 is a part of the common pathway, so we skip it and we put 9, factor 9 and factor 8. And the extrinsic pathway, can you guess it? Of course you can. It's factor 7. So those are the pathways, and basically they start as intrinsic or intrinsic but end up in common. So why is it called a cascade? Because factor 12 activates factor 11, factor 11 activates factor 9, factor 9 activates factor 8, then 8 activates 10, 5, 2 and 1, and factor 7 activates factor 10, 5, 2 and 1. So this is why it's called a coagulation cascade, and the goal of the coagulation cascade is to generate thrombin. And the job of thrombin is to convert fibrinogen to fibrin. So this is the reaction, fibrinogen to fibrin, mediated by thrombin. And again, let me just remind you that if this is a platelet, and those are platelet receptors GP2B or GP3A, okay, GP2B3A, and this is fibrinogen, which is connected to another platelet. So this thrombin will work, basically it will work on it and convert it to fibrin, making the platelet more stable. So this results in a stable platelet fibrin thrombus. So let's go back to the slide. So basically, secondary hemostasis stabilizes the platelet plug by the coagulation cascade. The goal of the coagulation cascade is to generate a thrombin, which converts fibrinogen to fibrin, and fibrin cross-links the platelets, creating a stable platelet plug. The coagulation cascade consists of factors. The factors are produced, sorry for the misspelling, are produced by the liver in an inactive state, get into the blood, and activated when needed. So the activation of the coagulation cascade, basically, first of all, they are activated by exposure to an activating substance. So let me just explain it to you. For example, the 12th factor of the intrinsic pathway, how does it activate? Basically, with injury of the endothelial cell, and in this injury, the endothelial cell is damaged, and the subendothelial collagen, which is type 4 collagen, is exposed. And factor 12 will be activated by this exposed subendothelial collagen. Get activated and will initiate the coagulation cascade and formation of thrombin. So this is an example of they get activated. Other activators which activate the coagulation cascade. Other stuff that are required for activation of the coagulation cascade. They are the phospholipid surface, which is basically the surface of the platelets, and calcium, which is found also inside the platelet granules, along with ADP and thromboxane A2, correct. So again, the coagulation cascade pathways, they consist of the intrinsic pathway, which consists of factor 12, 11, 9, and 8, extrinsic pathway, which is factor 7, and common pathway, factors 10, 5, 2, and 1. Vitamin K. I want to talk about vitamin K because our body uses vitamin K to produce a couple of the factors. So vitamin K is necessary to produce factors 2, 7, 9, and 10, and also protein C and protein S. And this occurs by the gamma carboxylation reaction and activation of epoxide reductase in the liver. So let's just read it. Okay, so first of all, vitamin K is generated by bacteria in our gut. It is necessary for production of protein 2, 7, 9, 10, protein C and protein S by gamma carboxylation in the liver. And it is activated by the epoxide reductase enzyme also in the liver. So let's just do a quick recap. So if this is our liver, okay, and vitamin K is present inside, it is synthesized by gamma carboxylation. It is necessary for gamma carboxylation, not synthesized by gamma carboxylation. It is necessary for gamma carboxylation of factors 2, 7, 9, 10, protein C and protein S. CS. So yeah, and it is activated by epoxide reductase. So again, vitamin K is required to make 2, 7, 9, 10, C and S. And deficiency in vitamin K will result, of course, in hypocoagulable state. Basically, we will have problem to form blood clot or platelet plug. And this deficiency is commonly seen in newborns because the gut is not yet colonized by bacteria, so they are more susceptible to vitamin K deficiency. So we give vitamin K prophylaxis to newborns to avoid hemorrhagic disease of the newborn. Vitamin K deficiency can also be seen in long-term antibiotic therapy because basically we kill the bacteria in our gut, and it can, of course, can also be seen in malabsorption because vitamin K is fat soluble. So if we have a problem with absorption of fats, it will result in malabsorption. I also want to talk about factor C and factor S. Basically, factor C and factor S, they are used to inactivate factor 5 and factor 10. Okay, vitamin C are used to inactivate factor 5 and factor 10. So basically, let me correct myself. Factor, I should say they are called not factors, they are called proteins C I would also like to mention a quick word about protein S and protein C. This protein. So again, they produced by the liver with vitamin K. They require vitamin K for the gamma carboxylation reaction which produces them. Basically, protein C and protein S, they are anticoagulants. So they are anticoagulants. Basically, they inactivate factors 8 and factors 5, and they are used to prevent hypercoagulable state. So they prevent, for example, formation of a thrombus, which may occlude the blood vessel and cause ischemia to an organ, or it may cause, for example, DVT, deep vein thrombosis, ischemia to our lower limbs. It may occlude hepatic vein or cerebral vein. Basically, it prevents hypercoagulable state and formation of a thrombus. So those proteins, protein C, protein S, are quite important. So before I finish up the lecture, I want to explain something about a couple of drugs, including heparin and comadin. But before that, I want to talk about fibrinolysis. So let's say our injury to the blood vessel is over, and we want to remove the platelet plug that is formed, the stable fibrin platelet plug. So the removal of the end stage of the coagulation, the removal of the plug, is called fibrinolysis. And this is not mentioning on the slide, but I want to so it's like this. Fibrinolysis is mediated by plasmin. Basically, in our blood we have a molecule, something that is called plasminogen. And this is basically an inactive form of plasmin. In order to activate plasminogen, we require TPA. tissue plasminogen activator. So tissue plasminogen activator activates plasminogen whenever needed, and plasminogen is converted to plasmin to lyse the fibrin cloth. And plasmin basically works by cleaving the fibrin. Okay, it also cleaves fibrinogen. It also cleaves the remaining fibrinogen itself. By doing that, it prevents future clot, blood clot or platelet plugs formation. It destroys coagulation factors, and it also blocks platelet aggregation. So four things: cleaves fibrin clot, cleaves fibrinogen, destroys coagulation factors, and blocks platelet aggregation. And this is not the this is not the only way in which fibrinolysis occurs. There's another molecule released by endothelial cells themselves. So whenever endothelial cells want to help in the process of fibrinolysis, whenever needed, basically you release something that is called heparin, like molecule, and this heparin-like molecule can activate antithrombin 3. Thrombin 3. Do you remember the function of thrombin? Of course, this is the end result of the coagulation cascade, formation of thrombin, which converts fibrinogen to fibrin and stabilizes the platelet plug. So antithrombin 3, activated by a heparin-like molecule released from the endothelial cells, basically it shuts off thrombin, like the name. It's very easy. Thrombin shuts off thrombin. So this is basically the main mechanism of anticoagulation, of fibrinolysis. So if we go back to the slide, we talk now about heparin. It works by activating antithrombin 3 by binding to it directly. So if if heparin-like molecules were released by the endothelial cells, they activate antithrombin 3. Heparin, the drug heparin, binds to it directly, activating it. Okay, so two mechanisms for antithrombin 3 to activate, by this and by this. So antithrombin 3 is an anticoagulant molecule that inactivates thrombin, which is normally produced by the coagulation cascade and converts fibrinogen to fibrin. So this is the function of heparin. Finally, I want to talk about warfarin and coumadin. They are more long-acting drugs than heparin. Heparin is like more shorter action. Warfarin or coumadin, they inhibit factors 2, 7, 9, and 10, protein C and protein S, and they are commonly combined with heparin initially to prevent warfarin skin necrosis. And what do we mean by that? So let me explain it to you. So again, warfarin or coumadin shuts off factor 2, 7, 9, 10, protein C, and protein S. Warfarin. So, first of all, initially, warfarin will shut off those two. It will shut off protein C and protein S. And as you know, protein C and protein S, they are anticoagulants. And this is basically why warfarin or coumadin have increased risk for skin necrosis. Initially, they will inhibit protein C and protein S. They are more correctly, they degrade them. So they degrade protein C and protein S. So factors 2, 7, 9, and 10, they will still be around for a time. And because protein C and protein S, they are anticoagulant factors, we have increased risk for thrombus formation. So basically, let's say a person is in hypercoagulable state, and we want to give him warfarin to prevent coagulation, because warfarin is an anticoagulant drug. If we give him warfarin, it will first inhibit protein C and protein S, and only then, after some time, it will inhibit those factors. So initially, when it inhibits protein C, protein S, the patient will be in an extremely hypercoagulable state. So it will result, of course, in increased risk for thrombus formation. Therefore, before we give warfarin, we tend to combine it with heparin, especially in patients with hypercoagulable state. If we give him warfarin, it's very bad. It's like a big risk for thrombus formation. Therefore, we must combine heparin with warfarin to prevent thrombus formation, especially in patients with hypercoagulable state. Then we can taper off, lay off heparin, stop giving it, and only give warfarin, which has long-term action. But first, to avoid the initial protein C and protein S inhibition, we combine it with heparin. Then after it starts shutting off factors 2, 7, 9, and 10, we can stop giving heparin and rely on warfarin. So let's go to the slide. Again, warfarin or coumadin inhibits factors 2, 7, 9, 10, protein C and protein S, commonly combined with heparin initially to prevent warfarin skin necrosis. Important. That's it about this lecture. I will do a future lecture about disorders of hemostasis. Let me know if you have a topic you want me to explain. I'll be happy to do a lecture for you. If not, probably the next lecture will be about hemostatic disorders. Hope you